Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. In this episode, we'll hear from Dr. Giada Bianchi, hematologist at the Amyloidosis Program at Brigham and Women's Hospital and Dana-Farber Cancer Institute. Adapted from her video, she'll explain the relationship between AL amyloidosis and multiple myeloma. AL, or light chain amyloidosis, has for years been viewed as a relative of multiple myeloma, as they're both plasma cell disorders. It is estimated that approximately 10 to 15% of multiple myeloma patients will develop AL amyloidosis at some point during their journey. However, there are important differences between the two, which can lead to diverging diagnostic criteria and treatment.
Good morning, everybody. My name is Giada Bianchi. I'm an assistant professor at the Harvard Medical School and associate director of the Amyloidosis Program at the Brigham and Women's Hospital and Dana-Farber Cancer Institute. I'm delighted to be here and to be giving this brief talk about what is the relationship between AL amyloidosis and multiple myeloma for the Amyloidosis Speakers Bureau. So both AL amyloidosis and multiple myeloma are part of a larger class of plasma cell disorders. This table outlines some, but not all, of the plasma cell disorders that we are aware of, and in particular outline the relationship in terms of incidence between multiple myeloma, a cancer of plasma cells, and AL amyloidosis. As you all know, is a plasma cell disorder characterized by deposition of a misfolded immunoglobulin-free light chain. You see here that while the median age of diagnosis is similar for these two conditions, incidence is reported to be quite different, with multiple myeloma occurring much more frequently as compared to AL amyloidosis. Now, we need to take this information with a grain of salt, as it is a well-established fact that AL amyloidosis may go under-recognized and undiagnosed, even in the setting of full overt multiple myeloma. And so these incidents and this figure probably underestimate the true incidence of AL amyloidosis in the US. It is also important to remember that about 10 to 15% of patients who have multiple myeloma during the course of their illness will be diagnosed with the overlapping AL amyloidosis. So even in patients that have overt myeloma, it is not so infrequent to find co-occurrence of AL amyloidosis. This is a table that outlines the diagnostic criteria for some of these conditions that we were discussing and compare one versus the other. Now you see listed here monoclonal gammopathy of undetermined significance, smoldering multiple myeloma, monoclonal gammopathy of renal significance, and AL amyloidosis. The major differences between MGUS, smoldering, and multiple myeloma are twofold. On one side is the burden of plasma cells in the bone marrow, where MGUS has the smallest burden, less than 10% of plasma cells by definition. Smoldering myeloma has an intermediate burden, 10 to 60% of plasma cell involvement. And multiple myeloma oftentimes has significant burden of plasma cell involvement in the bone marrow, although that's not always the case. The distinctive feature of multiple myeloma as compared to MGUS and smoldering myeloma is that there is always presence of end organ damage that is directly mediated by the plasma cells. So the expansion of the plasma cells in the bone marrow is directly responsible for end organ damage. So this is a critical feature that distinguishes multiple myeloma from AL amyloidosis. As you can see here, the end organ damage is really never mediated by plasma cells in AL amyloidosis as a standalone disease. So what mediates the end organ damage in AL amyloidosis is the deposition of the misfolded free light chain. This is also what differentiates AL amyloidosis from multiple myeloma in terms of proper definition of cancer. So by the book, a cancer is a condition in which you have clonal cells, meaning cells that are all the same, that are derived from the same progenitor cells that acquire abnormal mutation and had uncontrolled proliferation. So in these regards, AL amyloidosis and multiple myeloma both have clonal plasma cells as the driver of the disease. However, in multiple myeloma, these clonal plasma cells are directly responsible for organ damage, while in AL amyloidosis, the organ damage is mediated by the immunoglobulin free light chain that these clonal cells produce. And so the damage is not directly secondary to the expansion of the clone, but is actually secondary to a protein that is secreted from that clone. Now, this is really like a distinction that is semantic and based on what we consider the agreed upon criteria to call a disease cancer. However, pragmatically, AL amyloidosis is equally dangerous from the standpoint of inducing end organ damage, regardless of the mechanisms by which it does so. And so we actually treat this condition oftentimes in a very similar manner as we treat multiple myeloma. And certainly medications that work for multiple myeloma are active in AL amyloidosis. So why is that? So if we go back to the roots of how these disorders come about, the thought is that they share a common progenitor cells, meaning that the initial cells that acquire the driver mutations that cause the uncontrolled proliferation or lack of apoptosis, also known as cell death, is common between all plasma cell disorder. This is a post-germinal center B cells that we think acquire this initial mutation in the germinal center right after antigenic encounter. And then it terminally differentiate into a long-lived plasma cells that home in the bone marrow. Then over time, these abnormal plasma cells acquire more mutation and expands in terms of percentage of involvement of plasma cells in the bone marrow through the stages that we were discussing before. So first a small clone, the MGUS, subsequently a larger clone, the smoldering myeloma, and then eventually a very large clone of plasma cells in the bone marrow that are highly genomically unstable and with many mutations in the DNA. And now these cells are directly responsible for organ damage in myeloma, as we were saying. However, the thought is that the MGUS can also progress through a different path, where rather than going for acquisition of many more genome mutations and extensive proliferation, it actually differentiates and progresses to AL amyloidosis. How this happened, that the MGUS sort of decide whether to progress to multiple myeloma or AL amyloidosis remains unclear. But what we know is that the sequence of the immunoglobulin free light chain that determines stickiness, that determines capability to generate amyloid, is actually intrinsically determined at the time of the immunoglobulin rearrangement. So this is a very early event that occurs exactly at this point. And so cells that acquire the sticky protein probably have a tendency to progress through this pathway. And again, as we were saying before, what mediates organ damage in AL amyloidosis is the aggregation of this immunoglobulin free light chain in these sticky insoluble fibrils that then cause organ damage. As you well know, there is this major concern in AL amyloidosis, which is that it takes a variable amount of time for this aggregated free light chain to actually start causing symptoms that then become overtly evident as clinical symptoms or signs. And so that there is this lag phase where the free light chain organize first in small aggregates, then these aggregates become much larger, eventually generating fibrils. And then there is a threshold effect by which once there is a seeding of fibrils, then these seeds function as a dock, and so generates aggregation of fibrils much faster. So this is the exponential phase of fibril aggregation and deposition, where patients start to become very rapidly symptomatic, and we have a window of opportunity to diagnose them. Now, it's very unclear why certain patients have longer time to develop symptoms as compared to other. One thought is that the stickier the free light chain is, which is largely determined by the genetic sequence of the free light chain itself, the faster symptoms will develop. And this is sort of intuitive, as you can think that this light chain will have a tendency to aggregate and deposit much faster as compared to free light chains that are still capable of generating amyloid, but much less so. And so will take a longer time to generate these fibrils. So if you think in these very simplistic terms, and you go back to that little graph that I showed you before, where you have the clonal plasma cells that secrete the immunoglobulin free light chain, this then aggregates in fibrils and cause organ damage. You can sort of think, again, in very simplistic terms, that some patients will develop symptoms of AL amyloidosis when the clone in the bone marrow would be otherwise consistent with an MGUS stage of disease, so less than 10% of plasma cell involvement, if the free light chain that these cells produce is very sticky. Vice versa, if the free light chain that these cells produce is not very sticky, or if they produce very little per cell, patients may develop overt symptoms of AL amyloidosis at a stage of multiple myeloma. So where they have already progressed to multiple myeloma, they have organ damage determined by myeloma and a larger plasma cell burden in the bone marrow. So depending on the stickiness of the free light chain, the symptoms can occur at different free light chain or bone marrow plasma cell level. This is often creates a lot of confusion, as I get often this question, the patients ask, well, I thought I had MGUS, or I thought I had smoldering myeloma, so do I have two diseases at the same time? So not quite. So the AL amyloidosis is considered a progression of smoldering myeloma or MGUS to an active phase of disease. And so once you get a diagnosis of AL amyloidosis, the diagnosis of MGUS or smoldering myeloma cease to exist, as this is considered a progression event of a precursor condition. However, occasionally patients do have two conditions at the same time, meaning that they're diagnosed with active multiple myeloma, and so they fulfill criteria for having an actual cancer of plasma cells that requires treatment. And at the same time, they also have evidence of AL amyloidosis, and so the organ damage that is related to the amyloid itself. I thought I would put together a brief case to just outline some important features of why it's important that we think about AL amyloidosis in the context of multiple myeloma and vice versa. So this was actually a patient of mine, 61-year-old man with a history of bilateral carpal tunnel and progressive peripheral neuropathy with fatigue and bone pain that arose over the past 6 months. On exam, he had features consistent with the compensated heart failure with lower extremity edema, hepatic congestion, and a pleural effusion on the right. When labs were checked, you can see here that this gentleman actually had all the CRAB criteria, so-called CRAB criteria met. So elevated calcium, renal impairment, anemia, and then on PET-CT, there were diffuse bone lithic lesion. This was in the context of an elevated lambda light chain in face of kappa with an abnormal ratio and a presence of an IgG lambda M spike in the urine and in the serum. So this is a 61-year-old man with sudden onset of hypercalcemia, renal failure, anemia, and bone lesions consistent with CRAB criteria, progressive peripheral neuropathy, and stigmata of decompensated heart failure. So the suspicion was that this was a lambda-restricted multiple myeloma, was treated symptomatically for the acute renal failure and hypercalcemia with improvement, and then diagnostic studies followed. His bone marrow biopsy shows 60% involvement by lambda-restricted plasma cells. with a 1Q plus on FISH. And so he was diagnosed with multiple myeloma revised ISS stage 2. Subsequent to this diagnosis, a plan of care was made where it was treated with carfilzomib, lenalidomide, and dexamethasone, which is a triplet that can be used in the context of newly diagnosed multiple myeloma. Now, this gentleman throughout the first and second cycle reported were actually feeling much worse, with worsening fatigue, lack of stamina, and noted that his lower extremity swelling was getting worse rather than better, and his breathing was getting worse. Also noted that his peripheral neuropathy was getting worse, and actually there was no reason identified, and carfilzomib, which is notoriously not causing peripheral neuropathy, was chosen in place of bortezomib exactly to avoid exacerbation of peripheral neuropathy. So at that point, I saw him as a second opinion, and then he was sent to cardiology and neurology. So when he was seen by cardiology, there was evidence of elevated markers of cardiac damage, both the NT-proBNP and troponin. On EMG, neurology noted the evidence of axonal degeneration, and he had a cardiac MRI and echocardiogram that were diagnostic for an infiltrative cardiomyopathy. So at this point, the suspicion was that this was actually multiple myeloma with overlapping AL amyloidosis with advanced cardiac involvement and peripheral nervous system involvement. Underwent an endomyocardial biopsy that confirmed involvement by amyloid. This is a Congo red stain that showed the wrapping of the fibrils around the cardiac myocytes. You see here the red stain, and under polarized light, the apple green birefringence that is diagnostic for amyloid. This tissue was typed and consistent with light chain amyloid. So the treatment plan was actually changed at that point. So we moved him from KRD to DARA-CyBorD according to the Andromeda study, frontline therapy in AL amyloidosis. Free light chain normalized within 2 cycles, completed 6 months of quadruplet therapy, and then went on maintenance with daratumumab. At that point, we also added a very small dose of lenalidomide. Stem cell collection was performed, but a decision was made to defer autologous stem cell transplant in face of his cardiac symptoms. So why is this case outlining some important issue? So first of all, there were some red flags in the history of these patients, right? So the history of bilateral carpal tunnel should make you think about amyloid. This could be TTR, certainly, but in a patient that has a plasma cell disorder, you ought to think about AL as well. Unexplained peripheral neuropathy, again, think about amyloidosis in patients that have otherwise no explanation and cause for it. And then carfilzomib is a fantastic drug, is a very powerful proteasome inhibitor, but there is a signal of cardiac toxicity, and this drug should be used with caution in patients that have cardiovascular disease, including in patients with cardiac amyloidosis. Same goes for lenalidomide. This patient was dosed at a dose of 25 milligram, 3 weeks on, 1 week off. Lenalidomide tends to be very poorly tolerated in patients with cardiac amyloidosis and can worsen cardiac symptoms, including triggering the compensation of previously well-controlled heart failure. And so basically, the use of carfilzomib and lenalidomide in this situation probably unmasked previously unrecognized cardiac involvement in a patient with multiple myeloma. So why would we care about knowing that these patients has a amyloidosis in the setting of multiple myeloma? This is also a question that I get asked a lot. It's like, well, I'm getting treatment for myeloma anyway, right? So technically, you're also treating the AL as they're driven by the same process. So why would you care about recognizing these? I think this is, in fact, very important. First of all, it affects how we think about chemotherapy. So certain chemotherapy that are relatively well tolerated in patients with myeloma are actually very poorly tolerated in AL amyloidosis, and we can actually make patients feel worse based on the type of chemotherapeutic agents we chose. And so this is an important point. The second is that in patients with multiple myeloma, it's important to treat the disease so that the organ damage driven by the plasma cell clone is reduced and then reverted. However, there is not a whole lot of pressure in normalizing the free light chain very rapidly unless patients have cast nephropathy or other direct manifestation of free light chain toxicity. So you can have a VGPR in multiple myeloma patients with an absolute level of free light chain that is still in the triple digit. And that's totally acceptable for myeloma. However, it's really unacceptable for AL amyloidosis, as the damage that is derived from the free light chain that are still circulating does not abate unless the circulating free light chain is either completely removed or brought down to a very, very modest level. So the absolute quantity of circulating free light chain is key in AL, while cannot really be that relevant in myeloma. And then the third point is that these patients often have renal involvement, cardiac involvement, peripheral nervous system involvement, GI involvement. And so it's very important to get patients taken care of by a multidisciplinary team of specialists that can help with symptoms and signs related to the diverse organ involvement that these patients have. And finally, the co-occurrence of AL amyloidosis and multiple myeloma is a risk factor for outcome. And so one should always think about an autologous stem cell transplantation as a consolidation matter and to induce very deep remissions in patients that present with the AL and multiple myeloma. Now let's take the opposite situation. How about you have a patient with AL amyloidosis? Does it matter to recognize whether they also have overt and active multiple myeloma? And the answer to that question is also yes, for different reasons though. Number one is that myeloma requires certain features of treatment that are different in AL amyloidosis. For instance, maintenance until disease progression has been shown to improve progression-free survival, with multiple studies also showing overall survival improvement in patients that were maintained versus not maintained. So maintenance is not standard of care in AL amyloidosis, but it is in multiple myeloma. And so recognizing the overlap of these two disorders means that we should advise and counsel our patients for maintenance long-term until disease progression. Again, autologous stem cell transplant should be considered for the same reason we discussed before in the setting of the adverse prognosis of having both myeloma and AL amyloidosis at the same time. And then the other issue is the bone protective strategy. So our patients with AL amyloidosis often have a very small burden of plasma cells in the bone marrow, and we do not routinely offer bone protective strategy with bisphosphonate or RANK ligand inhibitors, as this is not standard of care in AL due to the fact that bone events are really not part of this disorder. However, they're a big part of myeloma presentation and an important risk in terms of quality of life and an outcome long-term. And so bone protective strategy should be offered and instituted in patients that have both multiple myeloma and AL amyloidosis. So having said that, I think you get like a little taste that this is a very complex field and that there are many moving parts, and it's very important that providers talk to each other and that we integrate several different aspects of patient's care that go all the way from the basic science that is really critical to develop novel therapies for both myeloma and AL amyloidosis, to education of colleagues and trainees, importantly, so that we can recognize these diseases earlier and provide better outcome for our patients. And then finally, the importance of multidisciplinary care to improve not just the quantity of life, but the quality of life, and so guaranteeing the best possible care to our patients. With that, I would like to thank the amyloidosis program at the Brigham and Dana-Farber, my lab, all our patients and their family, and our funding agency, both from philanthropy, government agency, and nonprofit foundation. I hope this was helpful, and if you have any question or concern, please feel free to reach out. Thank you very much.
For years, providers treating AL amyloidosis have borrowed therapies for multiple myeloma, as there were no FDA-approved therapies. Fortunately, in 2021, the FDA added AL amyloidosis as an indication for the use of daratumumab, in addition to its use for multiple myeloma, making it the first FDA-approved drug for AL amyloidosis. Today, There are studies underway to assess new therapies, as well as investigating combinations of existing therapies. Patients truly have more hope than ever before. I hope you enjoyed today's episode. If you'd like to watch Dr. Bianchi's video, please visit Mackenzie's Mission Education Hub at mm713.org. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.